Good afternoon, ladies and gentlemen. It's a real pleasure to give this seminar and to tell you really about a journey that started with a conversation about 38 years ago that I had with the then MRC Unit Director, Sir Donald Atchison, who was also the Chief Medical Officer, who suggested to David Barker that my research topic might be osteoporosis. And little did I know at that time that journey would still be continuing almost 4 decades later. So I will tell you a little bit about that continuously MRC funded program of research, touching on the burden and pathophysiology of osteoporotic fractures, and then just giving you a couple of examples of preventive strategies at different stages in the life course, very early during intrauterine development, and then right at the back end of life with primary and secondary strategies against fracture. But really the bottom line of that story is that who would have said that what 35 to 40 years ago was an inevitable accompaniment of aging would turn out to be a well-characterized disorder, have risk assessment and treatment and prevention through the life course mapped out just a short span of 40 years later. And for that, I remain completely indebted to MRC and its constant support. So you need to know where you're going in order that you need to know where you've come from in order to know where you're going. Osteoporotic fractures have been recognized since antiquity. They're recorded in Hippocrates' writings. The bottom left-hand panel here shows a vertebral fracture in a radiograph of a piece of spine removed from a Saxon barrow in Wales around the 8th century AD. The term osteoporosis was coined in 1850. And it took a full 100 years after that for Fuller Albright at Massachusetts General to document the importance of estrogen deficiency. A trial of hormone replacement therapy was undertaken in 1976 in oophorectomized women, showing an impact on bone density. But it was after I started that DXA, our principal imaging tool for risk assessment, was discovered. And then the last 30 years have led to a multiplicity of advances that I will illustrate for you today. So when I first started out, the debate was whether osteoporosis or falls were the cause of hip fractures. Hip fractures was rising in frequency in older people. And we did the first study that compared bone density with a very crude radiographic grading system that's shown in the inset, a 6-point trabecular grading system in the proximal femur, in people who had fallen and fractured and those who fell and didn't fracture, and very clearly showed that the risk of fracture increased among fallers with lower bone density. And that work allows me to pay tribute to my 2 mentors, both of whom were eventually in their life course MRC unit directors, David Barker and Paul Dieppe. At around that time, osteoporosis had been defined in words: low bone mass, microarchitectural deterioration of bone tissue, increased risk of fracture. And it's shown in the inset on the right. You can see that that nice, firm, honeycomb structure of trabecular bone is much more porous. Trabecular plates are thinner. The overall bone mass is reduced, and there is disconnectivity. And all of those increase fragility. But the measurement tool for that, as I've mentioned already, was dual energy X-ray absorptiometry, or DEXA. And that came into play in 1987. And a group of us 7 years after that came up with a quantitative definition of osteoporosis, 2.5 standard deviates below the young normal mean, which has come to be known as the World Health Organization definition. And that permitted the understanding of interventions that might reduce fracture risk sufficiently on the basis of their improvement of bone density. Now, since that time, there are a whole load of techniques that purport to enhance risk prediction. This is just one example that we use as a research tool. high-resolution peripheral quantitative CT, a CT scan of the forearm and of the distal tibia that more or less gives you, as you can see, images that are like a virtual bone biopsy. But these have not replaced DEXA in routine clinical practice for evaluation of osteoporosis. And the pathogenesis of fracture is really orthopedic in its simplicity. Any bone will break if it is weak enough, and any bone will break if you subject it to enough trauma. The complication comes beneath that line of bone strength and trauma. So we know that bone mass measured as bone mineral density by DEXA is an important determinant of bone strength, but a lot of other factors that are research tools contribute. We know that 1 in 3 people fall each year after the age of 70, but only 1 in 100 of those falls end in a hip fracture. And there's a lot of work on the type of fall and reducing intrinsic and extrinsic risk factors for falling that we don't have time to go into today, but that are important, as well as maximizing bone strength throughout the life course. So after my thesis work, as Claire said in her kind introduction, I went off to the Mayo Clinic, and you can see that the climate of the Mayo Clinic for 6 months of the year is conducive to continuation of research in the lovely facilities that they have there. And we mapped out, on top of the epidemiology of hip fracture that I'd done in my thesis years, the epidemiology of vertebral fracture, showed that there were 3 major fractures with advancing age: hip fractures, vertebral fractures, and distal forearm fractures, wrist fractures, if you like. That the vertebral or spine fractures, only a third come to clinical attention. And when you look at the incidence rates, the commonest are radiographic vertebral, of which, as I said, a third come to clinical attention. Hip fractures go up exponentially rather than linearly and cross the vertebral clinical line at about age 80. And distal forearm fractures rise smoothly with age. And all of these fractures are twice as frequent in women as they are in men above the age of 50. And it's the lifetime risk of these fractures from age 50 that leads to our lift conversation frequency of 1 in 2 women and 1 in 5 men will sustain an osteoporosis-related fracture. And the burden of these fractures has been mapped out for us. Hip and spine fractures have about a 20% impact on expected survival, and their cost is substantial. It's not as much as coronary artery disease, obesity, or Alzheimer's, but it's in that second group of non-communicable disorders, together with chronic obstructive pulmonary disease, the inflammatory joint disorders, osteoarthritis, and so on. And we know from very recent data that we've published just in this last year that the rise will continue with aging populations. We account for 3.5% of EU healthcare expenditure, about 5.3 million fractures each year in the 2030s, and rises in both men as well as women will be seen with demographic change. So now let's turn to preventive strategies. And you're well aware with something like this, where you have a continuously distributed risk factor, bone mass, that you can either try and move the population's curve of bone mass in a good direction, or you can assess risk and intervene in those at the highest risk, the so-called screening approach or high-risk approach. The first I'll deal with is the population approach. In order to undertake the impact of lifestyle and in improving fracture risk, you need to be aware of the changes in bone mass with aging and their determinants. So peak bone mass has a genetic contribution, and then there's nutrition, exercise, and hormonal status in the children, coupled with developmental programming that I'll come to in a bit more detail in a moment. And then for loss rates in women, estrogen deficiency at the menopause, coupled with thinness, are important, but also smoking, very heavy alcohol consumption, poor dietary intakes of calcium and D, physical activity, and various diseases and drugs such as glucocorticoids. And these risk factors are important because we can integrate them into a predictive tool for bone loss and fracture, and we can use them for population-based intervention. And when I returned from the States, I attempted intervention studies for vitamin D and calcium, and was involved in 3 very large-scale trials of vitamin D and or calcium supplementation that were published in the first decade of this millennium, all of which were tub-thumpingly negative. And so moving on from those, I followed the example set by David, who by that stage had shown that the map of coronary artery disease today looked like the map of infant mortality some 70 years earlier. And he then went on to studies in individuals to propose that persisting changes in structure and function caused by environmental stimuli during critical periods of early development might be linked to later risks of cardiovascular disease, diabetes, and obesity. And my work looked at the importance of that for osteoporosis. And there were examples of this with mechanistic underpinning throughout biology. This is just one example. Bee larvae, all genetically identical. If at a critical period of their growth, I give 3 days of royal jelly, all of them become workers. But if I extend that to 6 days of royal jelly, all of them become queens. And that's by the epigenetic switch of a differentiation pathway that's now understood by that extra royal jelly. So we set about the programming story for osteoporosis. And members of the team led by Elaine Dennison used our Hertfordshire Cohort Study, men and women born in Hertfordshire between the 1920 and 1930 timeframes, who had birth records, and they were then followed up through the NHS Central Registry to characterize them today. And these studies showed that low birth weight was associated with reduced adult bone mass and strength, that this was independent of the known genetic determinants of birth weight and bone density, which both have genome-wide association studies underpinning them now, and that this poor setting up of childhood growth was a predictor of hip fracture some 7 decades later. The other observational evidence came from mother-offspring cohort studies, a good example of which is the Southampton Women's Survey. And members of the unit here characterized 12,500 non-pregnant women aged 20 to 34 years in the city. They waited over a period of years for 3,160 to become pregnant. And we then looked at the newborn, followed up through into childhood. And next year, we're just going to be beginning the age 17 follow-up of these children. And those types of studies showed that the mother's vitamin D during pregnancy was a predictor of her child's bone mass when the child reached age 8 and 9 years. And that wasn't explained by the environmental characteristics of the child, its diet, physical activity, vitamin D status, and so on, but was explicable by the mother's 25-hydroxy-D level at around 20 weeks of gestation. We therefore then went on, because the observational data from around the world were not completely consistent, to undertake the first trial of this issue, the MAVIDOS trial. We took about 1,000 women at 12 weeks of pregnancy and randomized them to either receive a vitamin D supplement of 1,000 units or placebo. And you can see here, this study was led by a team at the unit under Nicholas Harvey. You can see here that 1,000 units, which is a relatively safe dose of vitamin D, less, for example, than the 2,000 units that have been recommended in pregnancy in the United States, corrected vitamin D insufficiency in 80% plus of the women at the end of pregnancy, with a frequency of vitamin D insufficiency around 40% at baseline. And the placebo arm remained unaltered. More importantly, when we looked at the offspring's bone mass, we found that the winter birth offspring were improved in their bone mass by around a standard deviation compare in the vitamin D treated mothers compared to the placebo treated mothers. And that was achieved in the right-hand panel here by correction of the summer to winter decline that would have happened in the winter births. So there was an important impact of season on supplementation. We just, in abstract form, demonstrated that this benefit persists at age 4 years in the offspring who have been followed up as a cohort from the treatment of the mother compared to placebo in the mother. And of course, we've begun to explore the mechanisms. And the mechanism that links the observations together here is fascinating. In doing epigenome-wide association work, we found that at a key locus in the promoter region of a gene called RXRA, which is a heterodimer with vitamin D in activating the genetic pathways downstream of vitamin D signaling, we find that methylation there in the observational data is related to the vitamin D status of the mother. And more interestingly, that in the trial, the supplement alters methylation of RXRA in its promoter region at these CPG islands in exactly the same direction. And so this particular story occupied a position in the MRC's delivery plan of a couple of years ago and has led to policy change in terms of pregnancy vitamin D supplementation. So now let's take you to much closer to the ages when fractures occur, the 60s, 70s, and 80s in the life course. I don't have time to go into the many agents we've discovered over the last 30 years that interfere with bone resorption by being anti-resorptive or directly promoting bone formation. All of these drugs act because in our skeletons, there's a turnover in cellular remodeling. And we were given this turnover because any inert structure would accumulate fatigue damage. So to repair that fatigue damage, we have a cell that resorbs bone, the osteoclast, makes a little hole in a plate of bone. There's then a resting phase, and then a bone-forming cell lines that hole, makes the matrix, which is type 1 collagen, and that matrix then gets mineralized with calcium hydroxyapatite to form the hard bony structure. And the drugs interfere with the resorbing cell or stimulate the forming cell. And they've been demonstrated in trials to reduce fracture risk by about 50%. We've also developed, using the historical risk factors that I told you and bone density, a risk prediction tool known as FRAX, work which has been undertaken jointly with the MRC Centre for Musculoskeletal Aging at the University of Sheffield. And with them, we've undertaken a multi-centre UK randomized control trial, 12,500 women aged 70 to 85 years, randomized to either FRAX risk-based screening or usual care, and then followed up with treatment of the high-risk FRAX group with bisphosphonates over a 5-year period. And the headline figure of that trial, which we published in the Lancet 3 years ago now, was a 24% reduction in hip fracture in the screened arm compared with the control arm, achieved by very high rates of GP prescription when they knew that a woman was in the high-risk category, and very high rates of adherence on the parts of the women with the bisphosphonate therapy. And on its own, that would be interesting enough, but coupled with similar studies in the Netherlands and Denmark, which have endorsed these effects, primary fracture prevention with bone density and FRAX-based screening at age 70 to 85 years have returned to the public health agenda. Secondary fracture prevention is also a low-hanging fruit in this preventive story. We've known for many years, these are our data from the Mayo Clinic days, showing that if you take men and women who have had a first vertebral fracture, by the time 1 year has passed, 20% of the women and 17% of the men have had a fracture, and by 2 years, 30% of the women and over 20% of the men. So identifying people who've had a first low trauma fracture, assessing risk and intervening seems sensible. And together with the team at Oxford, we've undertaken a natural experimental study looking at what happens when you intervene with fracture liaison services to identify, risk assess, and appropriately treat men and women who have had a first low trauma fracture. And you can see here that there's a downturn in the 3-year impact in terms of second fractures, and there's an upturn in the frequency of densitometric evaluation and pharmacological prescribing. And that has matured with additional trial evidence that I don't have time to show you, validating secondary prevention into a global policy which was launched only during the emergency last year to support secondary fracture prevention, that includes mentorship, implementation of policy change, coalitions, scalable solutions, and a digital tool that we've developed for fracture ascertainment worldwide that's undertaken between the unit, these 2 universities, and the International Osteoporosis Foundation. So I've been able to tell you in a really compressed form of a life journey professionally in osteoporosis research. A life journey that was only made possible by the MRC funding that I and the unit have enjoyed. So the population and individual mortality and morbidity burden attributable to osteoporotic fracture is well established. Risk assessment in later life has been individualized through this FRAX algorithm, those 11 historical questions with bone density when appropriate. That incorporating such a strategy to reduce fracture by targeting women aged 70 to 85 years in primary care can lead to an approximately quarter-fold reduction in hip fracture incidence, with a pragmatic randomized control trial in this country and 2 others in other parts of Europe supporting this strategy. That secondary fracture prevention is effective by natural experimental data, a different design, and that this requires implementation worldwide now that we recognize how high fracture risk is immediately following a sentinel fracture. I've shown you the developmental contribution to osteoporosis, of course, providing a population-based approach many decades into the future, and the impact that gestational vitamin D supplementation might have in influencing neonatal bone mass, and MAVIDOS and its follow-up trial SPRING, which still needs to be completed, are explanatory randomized control trials. And these are examples of the integrated Lifecourse Preventive program against osteoporosis, which is now feasible and within our ability to put into health policy. So what then for the next 5 years? So our objective is to pursue other questions within osteoporosis, but linking to musculoskeletal aging as a whole. The commonest joint disorder worldwide, top left, is osteoarthritis, and the commonest muscle disorder worldwide, top right, is sarcopenia. And we know that the disorders of musculoskeletal aging, osteoporosis with OA and sarcopenia, will account for a major burden of disability predicted by the global burden of disease extrapolations by 2035. And so undertaking mechanistic work and interventional work in this triangle of bone, joint, and muscle remains our work for the future. But for today, it just remains for me to thank you all for joining, to thank the MRC for the importance and constancy of its support, and of course to thank the many students who have trained with us and who are now, of course, the professors of today, and I am now learning from, and they're all listed here. Thank you very much for your time, and I do look forward to your questions. Thank you.